Good afternoon, everyone, and thank you for attending today's webinar, Understanding the Ins and Outs of Payer Audits, presented by Jim Tudor, Director of Billing Compliance with Healthcare Compliance Network. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, if you would like a copy of the presentation slides to keep or print and take notes on during the webinar, please find them on the right of your screen in the Handouts section. They will also be emailed to all participants following the completion of today's webinar, as well as a recorded version will be available on the website for members only. Again, we would like to thank you for attending, and I will now turn things over to Jim.
Thank you very much. Good afternoon, everybody. As mentioned, I am the Director of Billing Compliance for a company called the Healthcare Compliance Network, or HCN. And hard to believe, I was thinking about this the other day, I can't believe I've been in this business for now 31 years, starting out as a biller, then worked for the insurance company for a couple of years on the quote other side, processing health claims. I've worked in coding and compliance departments for a number of major institutions throughout the Northeast. For the past 15 years or so, I've been working with the principals of the Healthcare Compliance Network, serving as their director. I oversee a team of auditors who are charged with conducting our due diligence chart audit reviews, just for the folks who are interested every now and then in doing a spot check on their billing and coding to make sure that they're compliant. Over the past three or 4 years, I'd say we are starting to become host partners with several law firms that send over clients to us that have been audited and have received a nasty letter saying that they owe a bunch of money, or that are concerned that they may be susceptible to an audit due to certain billing volumes and perhaps providers who have aberrant billing distribution patterns and things along those lines. And we take a look to make sure that everything looks good. Today, what we'll go over are four main topics. Number one, what triggers a payer audit to begin with? Number two, how to prevent them to begin with. Number three, how to respond in the event the audit is initiated. And most importantly, the fourth one, which you don't see listed here, but as we move throughout these various aspects of medical services that are ripe for billing audits in this day and age, I will infuse plenty of best practice recommendations as to how to code, what to avoid, time permitting. I think we should be able to get through pretty much all of that. Those best practice recommendations are worth their weight in gold. And it's because a lot of it has to do with the phraseology that an auditor would be looking for in the event of an audit. They're looking at your note and they're not finding certain elements that are kind of hidden in plain sight, but maybe not worded to their satisfaction. What you'll hear throughout some of the recommendations may make you scratch your head a little bit saying, gee, do we really need to say it like that? And given the fact that I've been so involved in these matters over the last few years, I can tell you with concrete certainty, absolutely, word things a certain way. Sometimes a provider will come to me saying, hey, do I have to use that verbiage on my review of systems that you recommended, or do I need to say this and that when I'm billing on the basis of time? I can tell you that many of the adverse determinations that I've seen over the last couple of years, much of it is related specifically to the terminology that's used in the notes. Sometimes I'll see statements which seem to infer, like a shortcut on the review of systems, as I say, or that a counseling session with the patient occurred. It was mostly a talk visit, but it's not really worded in such a way that accurately facilitates billing compliance. So with that being said, as we move through the various areas, as I mentioned, I will be sure to throw in some key points here and there. as to how best to document that particular situation at hand. So in taking a look through the agenda items, known triggers, and I will say that right now there's probably all of these and a few more. Currently in the state of New Jersey, I can tell you that, pretty much all of the payers are active to some extent with their auditing initiatives, but by far and away, the most active is Horizon Blue Cross Blue Shield and Horizon NJ Health. Of every 10 audits that come across my way, probably 8 or 9 of them are Horizon or Horizon NJ Health. They are very, very, very active, and these items and a couple more that I'll mention are definitely on their radar, starting with high-level visit codes, E&M codes. When I refer to E&M, I'm referring to evaluation and management, which I'm sure you're all aware are your office visit and consult codes. Peer comparisons, I had an audit a couple of years ago. A provider said, I've been working with this particular physician for many years. And he says, I followed all your tips, or at least so I thought. Why are they doing this to me? And I looked at the letter they sent him, and it says, Dear Doctor, this audit was initiated because you bill 100% level 4 consults. So I can tell you it's hard to tell where that fine line is sometimes as far as what billing distribution will trigger an audit. But if you're billing 100% of any particular code within a specific subset of similar codes, like consult codes, there's 5 levels, you bill 100% level 4, or any level for that matter, it infers, potential miscoding because just the nature of the beast, they know there has to be some variance there. Unbundling, which is the fragmentation of a particular procedure or service into multiple codes when one comprehensive code exists, that's definitely a no-no. Or along those same lines, using a modifier to unbundle when it's not truly supported. Incident 2, which is the CMS provision that governs when a service is with an NPP, non-physician practitioner, such as a PA or an NP, may bill under the doctor and receive full reimbursement. Some of the payers have their own variations on that too, which we'll talk a little bit about. Policy violations. I'm referring to medical policy violations that are posted by the payer. In the Medicare space, they have 2 things, most notably one called the LCD, which is a medical policy setting forth the not just the coding guidelines applicable to bill a particular service, but medical necessity as well. Quite often we get audits where someone is not meeting the medical necessity guidelines. They may have coded it correctly, but they're not meeting the frequency standards, or patient is not exhibiting all of the signs and symptoms or past history, which supports billing for the service. And the NCD, which is national coverage determinations, that's something that's handed down at the CMS level as pretty much guidance for the Medicare payers and for other folks who are just interested in having a general understanding as to CMS particular stance on a particular service type or issue. EMR issues, and I'll say out of those 10 audits I referred to, probably 50% of them, there's one or more issues that circumvent EMR issues that, like information carried forward, conflicts within the note, things along those lines, that it to some extent have been led the auditor to discredit portions of the audit, or not give you credit for certain things that they should have. So we'll go over a little bit more detail on that. Whistleblowers, that's also another way that, of course, you can get in hot water. How to respond, we'll go over the review and appeal process. Those interventions such as self-auditing and implementation of policies and procedures, which are very helpful. Provider and staff education, quite often it's not just the providers that need to be educated, but also anyone who has a hand in the billing process, who may be responsible for changing codes or validating codes, or something to do with the EMR, And speaking of, EMR modifications, how to make your notes an accurate depiction of the service that was performed in such a way so that it renders your documentation essentially bulletproof in the event of an audit. That's always the goal. When my company does an audit, a due diligence type of review on a particular practice, there's 3 buckets. I tell my team this all the time. There's agree, which means you conclusively agree. Disagree, which means beyond a shadow of a doubt, they're off by a country mile. And the third one, which is the biggest area of all, which is let's talk. Maybe sometimes the way that certain statements are phrased, or the way that the EMR is displaying certain pieces of information, don't work to the physician's advantage when it comes to supporting the billing. So it's good to have, some checks and balances and some knowledgeable folks on hand who can, who are aware of the guidelines and who can make necessary modifications to try to go towards that ultimate bulletproof goal. So now let's talk about some of the triggers for an audit. Again, starting with the E&M codes, I can tell you that almost every audit that comes across my way has, in part, due to overutilization of the high-level codes. So for a new patient office visit, that's 99204 and 5, established patient level 4 and 5, and then consult level 4 and 5. If you file too much off the norm in your area from a billing distribution standpoint, it's going to get some attention. So I'd mention 100% of any one particular level within a family of codes is guaranteed to get you some attention. So short of 100%, where is that fine line? It's hard to say with 100% certainty, and the payers don't really publish that kind of information. But in my experience, if you have a variance in any one particular code, 20-25% or greater off the norm. And again, the benchmarking is done not only geographically, but by specialty. If you're over 25%, there's a chance it could get some attention. Does that automatically mean you'll be audited? Not at all. But it's usually those folks, again, when they come to us, it's like, yeah, I bill, 70% level 4s, and I look up the specialty billing distribution in the area, and it's something like 40%. So as a very general benchmark, let's say 20-25% off the norm. So it's good to keep track of those things. And with regard to the last one here, the consultations, I can tell you this is still a tremendous hotspot. It always was back in the day when Medicare actually paid for those codes. As many of you are probably aware, in 2010, they stopped paying those codes. They just said, go ahead and bill as a regular office visit or hospital visit, whatever the case may be. And it was thought at that time that many of the payers were going to follow suit with Medicare and no longer honor those codes. And in fact, what's happened is it's probably 50%. It depends. It's geographically specific, or seems to be to some extent. But probably 50% of the codes, I can tell you Horizon and Horizon NJ Health do honor the consultation codes, and they are very active in auditing those particular codes. So you have to worry when a consult is involved. You not only have to worry about whether or not the level you're billing is accurate, but also that you're documenting that to support use of a consult code to begin with. Technically, by definition, a consult is a request for an opinion or advice regarding a specific problem or how to manage a specific problem. And there's certain buzzwords and phraseology that you've got to use in your note. You should always preface your note by saying, I am seeing this patient in consultation at the request of whoever the provider is, and then clearly state the rationale for the consult. And that may seem, well, do I really have to say it that way? Can I use the word referred by? Absolutely don't use the word referred by. I realize the semantics are confusing here, and you may be thinking, what's the difference? I mean, they were technically referred. inherent to the guidelines for consultation, it says specifically in the coding nomenclature that a consult must be requested by PCP or other valid source. The word referral to an auditor infers on some level, and I don't even know exactly why, but it's become a thing with auditors they see the word referral and they automatically think this patient is being referred for treatment and nothing else. The diagnosis is known, the treatment is known. There's absolutely nothing about this particular problem that the PCP or the other provider who requested it really needs to know. It's just a straight up, referral to treat the problem. So that being said, avoid using the word referral, number one. Number two, the patient is self-referred. Don't bill that one as a consult because it's absolutely going to get dinged. And if you look at the CPT section notes, it clearly says a self-referral. Patient is relocating or they're seeking to reestablish specialty care, things along those lines, would not constitute a consultation. So there's a lot of, little nuances there. And finally, make sure that your note shows some evidence that the requesting provider received a copy of your note. Several ways you could do that. You could do CC Dr. PCP. You could do a courtesy letter back to Dr. PCP and say, thank you for referring your patient for consultation regarding ... Make sure that there's evidence of communication. Sometimes what happens is the notes are faxed or emailed back to the requesting source, and the insurance company is looking at the note saying, well, it's not a consult unless there's some evidence that your note went back. Of course, you did it. The question is, can you show that you did it? And that's immensely important. I've seen consults get dinged and recoded as new patient or in some cases established patient encounters for lacking one or more of all of that criteria that I just mentioned. It's such a hot spot that I hyper-focus on this for a couple of minutes because I don't want anyone else to experience some of those unpleasantries which go with the territory. So definitely keep an eye out on consults if you're billing those. Prolonged care is a secondary E&M code that you can bill when you exceed certain time thresholds associated with the E&M. So it's a secondary, you bill it in addition to your office visit code. Sometimes those are miscoded because the provider didn't spend enough time or they didn't document the time in a way that's clear enough to be able to give credit for prolonged care. I don't see a lot of that. Most providers are not either not aware of the prolonged care codes or are a little reluctant to bill them because of all the ambiguity associated with it. But usually when I encounter a provider that's billing prolonged care who's been audited, it's almost always a point of focus. Pitfalls, not meeting the comprehensive criteria. Again, we're looking at all high-level E&M codes here. So comprehensive history is a full HPI. It's a 10-system review of systems. It's complete past medical family social history. It's a comprehensive 8-organ system exam, or for you specialists out there, it's whatever the complete single organ system exam as defined by the 1997 E&M rules. You have to meet all of that criteria. And if you're even off by a little bit, if let's say you have all of that criteria met, except you have 8 ROS in your note instead of the 10 that's required, that alone is essentially the low-hanging fruit that an auditor would be looking for to say, you know what, even though the complexity is here and the medical necessity is certainly there, you did not meet the criteria, all of the criteria that's associated with that code you built. Doesn't seem fair, and in fact, in a couple of years, there are some interventions which Medicare is considering which will tremendously reduce the documentation burden associated with the history and the exam in particular. For now, we still have it, and we don't know exactly what shape and form things are going to take, but there are major changes brewing along those lines. But in the interim, make sure that you're meeting all of that criteria. Number two, suboptimal documentation of medical decision-making elements. You know, when I meet with a provider, I'll go over all of those things, you know, such as the data points. The data points are all elements which refer to the number of tests and the type of tests that you may have ordered. Things like discussing the case with another provider, calling the radiologist to discuss abnormal films, reviewing images versus reviewing a radiologist report. All of those little nuggets that fit into the medical decision-making have enormous value in the event of an audit. Some of it is fairly commonplace. You know, you may always look at the images. You may it may not be all that uncommon for you to call the PCP and discuss, or as I mentioned, the radiologist, discuss what's going on with the patient. Those things, when documented, could be the difference between one level of medical decision-making and another, which could in turn be the difference between a level 3 and a level 4, which in turn could be the difference between getting one of those ugly letters that I mentioned at the onset versus getting a letter that says you passed with flying colors. Make sure that you document things like that because they are immensely important. Maybe doesn't move the needle much for patient care or any to record those things. In the event of an audit, they are worth their weight in gold. Trust me. Failure to effectively document time-based scenarios. Sometimes I'll see, I spent 20 minutes counseling the patient. So you know that the provider is on to that provision that allows you to bill an office visit by time, but they're not including all the elements that are required to do so, such as number one, you have to mention the entire duration of time spent in the room with the patient. I spent 40 minutes face-to-face with patient. Number two, define the encounter as over 50% counseling or care coordination. I'm thinking that more likely the former than the latter. And number three, make sure that you do a fair job at describing the nature of the counseling. If you're billing a high-level office visit on the basis of time or perhaps even prolonged care, you should drop a good solid paragraph into your note describing the nature of counseling that was provided. Sometimes I'll see a beautiful time attestation in there, but you really can't tell what was talked about. If you already have documented that within the body of your progress note, you can refer to it by saying, see above for essence of discussion or something like that. But there has to be a pretty solid description in order to bill on the basis of time, and by all means, make sure you use all the buzzwords and phraseology that I just mentioned. Peer comparison. So I mentioned already that code volume is definitely a trigger. And again, generally speaking, 20 to 25% off the norm with any one particular E&M code. Sometimes the benchmarking extends to certain types of procedures as well, where there's a family of codes, and you know they benchmark by looking at the distribution. If you bill for a comprehensive code in a family, a subset of CPT codes that also includes limited, you know, like echocardiograms and things along those lines, you can be an outlier in that respect as well. It's not just the E&M codes. Also, excessive use of modifiers. And the two big ones that I see coming my way every day in these audits are modifier 25 and modifier 59. Modifier 25 is the guideline that provisions when you can bill for an office visit and a procedure or other service. And in primary care, you can also bill for a sick visit and a well visit on the same day using the modifier 25. This is a hot spot right now. General rule, if you are doing a procedure that was planned in advance, you knew when the patient arrived in the office that day that you were going to do a procedure, and nothing else is addressed except all the procedure itself and all of the typical inter-service work that goes with the territory. Don't bill the E&M code. It's in addition to that. Just bill the procedure. It's a different story if the patient says, oh, by the way, can you take a look at this? Or, oh, by the way, I've had, you know, some symptoms that are clearly unrelated to the reason why you did the procedure. That's a whole other ball of wax. And that would support a modifier 25. In the well visit situation, Typically, the ones that get, if the patient has an acute issue, they happen to be, have an ear infection or URI or something is going on that particular day, it's usually not an issue with the payers. They'll usually accept that. It's the chronic conditions, which sometimes if everything is stable, there's no changes to medications, it's just continue everything the same. Sometimes the payer has a tendency to deny the modifier 25 and the problem visit in those circumstances simply because they feel that that monitoring of chronic issues is included in the well visit. I disagree with that to some extent, and the work RVU associated with a well visit doesn't really, it encapsulates mostly just the routine work that you would do for a healthy patient of that particular age group. Because remember, the well visit codes are based on the age of the patient and all that typical work that you would do for a patient of that age. It can't, when they're going through and figuring out the RVUs, they can't really know, does this patient have, 1 or 2 chronic problems, or do they have 15 chronic problems that are being addressed? So sometimes if everything is all well and good, the payer has a tendency to deny that. I'm pretty successful with the appeals in that situation, but I'm just giving you that word of warning, to kind of watch out for that situation. Number of units, there are something called MUE edits, which are making reference to, and MUE stands for medically unlikely edits. So if you bill a particular injection with 10 units of service on that particular day, and it could be just a data entry error or something along those lines, but there are checks and balances in place. Just please be aware on that. Site of service, the big one I think is billing for an office visit, place of service 11 versus billing it as part of a hospital institutional setting, POS 19, or I believe it's 22. The POS 11 is a global code which captures all of the work, including overhead, that goes with the territory, versus the facility codes, which are generally being used to split the work between a professional component and all of the overhead that goes with that particular service level. Sometimes the provider, or the payer, will look at the billing distribution and something looks out of whack as far as site of service. Deleted codes. If you're billing deleted codes, that could be a major red flag to the payer. It can indicate a couple of things. Number one, that you may not have a full handle on, updates. The CPT code catalogs are updated annually. There are typically a bunch of deleted or revised codes. If you're billing for those codes, repeatedly, although I would think you'd get denials and that would be a flag to change it, but were that to happen, it could infer to the payer that you're attempting to bill for services that are just not even represented by correct CPT code anymore. So make sure you stay on top of things like that and edit your EMR if necessary, or encounter forms if you're using a paper super bill. Impossible days, I have been involved with a few of those, and basically an impossible day is referring to a situation where it particularly applies to E&M codes, because most of the E&M codes have an average inter-service time that are associated with them. I have been involved with audits where they just simply, the payer added up all of the E&M codes on an average day that are billed, and coming up with, in one case I had a provider that was billing for a 40-hour day, just simply because the volume was above and beyond what the payer determined to be possible. Turns out that was a very hardworking gentleman who was seeing patients in his office, in the nursing home, and also in the hospital on the average day in all 3 locations. So interesting story. I won't get into the nuts and bolts on that, but this is a potential red flag if your billing volume, particularly for E&M codes, is high. They could add up the typical times and say it's just not possible. That can give rise to an audit. Now, at the end of the day, what it all comes down to is your note. Even though it may say a particular code may say in its description 25 minutes, for example, 99214. you can still do a valid level 4 visit if you spend less than 25 minutes. That's only used as a guide when in that counseling/talk visit scenario. So typically what happens is providers, especially the well-seasoned providers that can see the patient in a lot shorter period of time than maybe some of the newer folks that are also involved, they can see a level 4 encounter in 5-10 minutes, and that if you build too many of them, it drives up the volume and it could lead to the payer questioning it. Unbundling is referred to in the guidelines as fragmentation of billing into separate CPT codes when a single comprehensive code exists. The only way to know really is to just have to either be acutely aware of this particular scenario, and if there are multiple codes you'd bill, or it's all kind of globally encapsulated within one or more than one CPT codes. The National Correct Coding Edits, or NCCI, is one way that the payers use to determine whether or not you're billing appropriately. And you can also look at the CPT section notes, which also, I think, go by the wayside. Just crack open a CPT book in a section that precedes the codes in question. Usually have pretty clear guidance as far as what codes you can bill in what scenarios. Medicare took that one step further and implemented the CCI initiative. And basically it tells you, is the code that you're billing for appropriate, along with any number of other codes that you could potentially be billing, and it'll tell you in no uncertain terms. You can look it up on the CMS website. For you coders and billers out there, you're probably aware of ways you can, if you're using, AAPC Coder and Coder Pro and things, Optum, I think they're called now. Software well along those lines will give you that type of information as well. There's no real reason. I could tell you that Horizon and Horizon NJ Health do check those CCI edits, and Modifier 59 is a definite hotspot. Essentially what happens when you use the Modifier 59 is you're saying that a code that's ordinarily bundled was appropriate under the circumstances. And sometimes it is, sometimes it may not be. The only way to know for sure if it's hitting an edit is to actually look them up, unfortunately. They do strive to, when they do the updates to CPT, they strive to consolidate multiple codes into a single code as often as possible to avoid this situation. But sometimes it's just not possible, and you just have to check. And CPT nomenclature, that's the section notes I was referring to, or the code descriptions right in the CPT book, which sometimes give you some pretty fair guidance, and sometimes will direct you to another code or series of codes that you could use in addition if there isn't one comprehensive code to capture the full situation. Incident 2, these are the guidelines provisioning. This is primarily a Medicare guideline that has been adapted into certain variations by the payers related to billing for the services of NPs, PAs, nurse midwife, social workers under the doctor, and thus receiving full reimbursement under the fee schedule, versus those providers billing as an independent service, i.e. under their own billing numbers, and receiving usually 85% of the fee schedule. That 15% differential is what the payer is looking to validate, to make sure that you met all of the criteria associated with that particular provision in the guidelines. There's several key considerations, including supervision. There are almost all, in any variation, because the payers, again, don't necessarily follow Medicare to a T on this, but almost all of them have a requirement saying that in order to bill under the doctor, there has to be an MD on site and immediately available in the office suite at the time service was performed. Site of service considerations, sometimes I will get an audit where a provider is billing incident 2 in a facility setting. So a patient is, let's say a PA is rounding on patients. They're all being billed under the doctor. In a facility setting, you can't do that. There's a variation of the Incident 2 guidelines called a split shared visit. And it's basically the same thing. The billing can go out under the doctor, but both providers have to see the patient, and both providers have to do the note. The NPP or PA can do a full progress note like they normally would. The MD has to do an attestation that says, I saw the patient and I agree, and a couple of key points relative to that, whatever the most salient points are in that patient's care at that particular point in time. You have to touch upon all of those from a documentation perspective. That's what the auditors are looking for. But to just bill a PA or an NP visit in a facility without the personalized visit by the MD will not work. Both providers have to see the patient facility setting. Now, I mentioned there are other payer variations on this. Some of the general rule of Medicare is that in order for a service to be billed incident to, there has to be an initial visit by an MD for a particular problem. Sometimes that's misconstrued a little bit as, oh, as long as the doctor does the first office visit, period, everything thereafter is incident to. That is not the case. Incident to means there's an initial visit by a doctor for a specific issue, and then the NP follows them for that specific issue, following the plan of care that's set forth by the MD. So in other words, a patient, let's say cardiology patient has an initial visit for CHF, and they say, well, you're going to see Nancy, our nurse practitioner, for all of your follow-up visits for the CHF, and then a year later, the patient develops AFib. Well, that's a new problem at that point, assuming it is a brand new problem. The MD would have to see the patient for the AFib, say, here's what we're going to do, and you need to follow up with Nancy or whoever NPP in the office for your AFib moving forward. The MD also has to see the patient periodically on their own to stay in touch. There's no particular guideline that says thou shalt see them every 3 months or 6 months, but you have to see them as medically necessary every so often. Now, some of the other payer variations don't follow that aspect of incident to, so beware of that. Some of them are actually a little bit more relaxed. Others are even more stringent. Be aware of what your payer requirements are. If there is payment differential for incident to, make sure that you're aware of what the guidelines are and make sure that you're following them to the greatest extent possible. Medical policies, and this is the LCDs and NCDs I was referring to earlier, which set forth the terms and conditions upon which certain types of services are payable. At the Medicare level, your carrier Novitas has a whole bunch of local coverage determinations which tell you in no uncertain terms what the medical necessity criteria and coding guidelines are associated with that particular service. Common violations in the audit world. Services too frequent. If you're billing for a particular service that is only covered once every 2 years and you billed it 3 times over the course of 2 years, there's a chance that could trigger an audit. Of course, it all comes down to medical necessity most of the time anyway, but this kind of thing can give rise to an audit. Often you can appeal situations like that if you can justify the medical necessity. But it's still not a situation that's comfortable by any stretch of the imagination. Correct coding, I mentioned that the LCDs are filled with information on how to code. And then, of course, the medical necessity is the overarching criterion for anything Medicare and pretty much everyone else. It has to be inherent based on whatever the guidelines and the policy are set forth. EMR issues, I'd mentioned this is a hot spot. First item here, fragmentation of documents which support coding. There are a lot of little cubby holes in the typical EMR where documents could be stored. You could have a flow sheet, a shot record. You could have a procedure notes, everything that's not really tied together into the progress note. It may all be associated with a particular encounter note, but if you're ever called to task on that in the event of an audit, make sure that you're pulling all of the documentation that supports all of the coding for that particular encounter, because they're going to look at everything. They're going to look at the E&M codes, the procedures, everything. If you send the progress note and there's reference to a flu shot that was, quote, ordered in the progress note, but it doesn't conclusively say that it was given. I actually had an audit this week. That's exactly what the case was. Make sure that you're sending all of the notes that support all of the codes. Okay, and it's always best to, if you can customize and, you know, have one-stop shopping in that situation, click a big shiny button that pulls everything together. In situations like that, it definitely works to your advantage. Cloning and conflicting documentation, which is something that still remains on as a hot spot. The way that I always regard this is, when I'm educating providers, is change what changes. There's no need to go in and rewire your HPI every single office visit just for the sake of making it look different. Sometimes things will stay constant over the course of time. There's no need to change that, but if you don't change the things that do change, I've seen serial reviews where they'll look at all of Mary Smith's charts going back 3 years, and sometimes if they don't see enough deviation or appropriate editing when necessary, that can cast aspersions on the integrity of the note. They feel that compromises the medical necessity if that note isn't a true reflection of what occurred. So make sure that you do, a little extra TLC before closing out of that note will go a long, long way. Inappropriate use of templates. I've seen situations where, it's easy to click the, I did all the review of systems button in the EMR, or, full exam every single patient. If you're not doing that work, make sure that you, or you're only doing a part of that work, let's say, make sure that you edit that. So again, every time it's a true depiction of what you did. If they see, comprehensive level services or comprehensive documentation, but it doesn't align with the medical necessity of that particular condition, it could give rise to folks kind of raising an eyebrow there. Coding calculators, which some EMRs have, I have found are not very accurate for the most part, especially due to the medical decision-making aspect, which is subject to, more gray areas and subjectivity than the rest of it. It's hard to, how much is enough when you're summarizing notes? How much information do you need to put in there? That's hardwired into the medical decision-making aspect. If you say 2 words, did you say a paragraph? The way that an auditor calls that versus what a EMR will pick up on for coding may be a little off kilter. So in my experience, there's, that's usually the medical decision-making aspect that's the most problematic. Whistleblowers, this is definitely a way to get in hot water, and that could be staff members, competitors, patients, anyone who has inside knowledge or suspects that there may be a billing issue or even potentially fraud. The government actually encourages that. And in the end, they could receive 15 to 30% of any recoupments that are gained. Reportable violations typically include billing for services not rendered. Some of these we've already gone through: upcoding, unbundling, medically unnecessary services, improper cost reporting, kickbacks, self-referrals, and probably a few others. Basically anything on that list of items that we went through, modifiers. If someone has inside knowledge of that, they can look into that. And I don't see a whole lot of that, but it does happen from time to time. We will get called in to check out those situations too. So still going on. How to respond. So with appeals, follow all of the direction in those correspondences. So there's going to be, typically what happens is, you'll get a letter to initiate the audit for medical records. Sometimes, depending on the payer, you can use a portal and upload the medical records. In the letter, it will tell you specifically what patients and dates of service. It will tell you what items to include, and it will tell you how long you have to submit those items. Make sure you follow all of those directions to the T. Otherwise, things could go astray on you and start leading to some unpleasant circumstances. Self-audit and research, that's my forte, personally. All of those occasions where we're being asked by an attorney to take a look at an audit, we're looking at the viability of potentially lodging an appeal. And I would say probably 80–85% of the time there is some foundation to do so. It involves a lot of research at times to make sure that the citations that are being quoted are appropriate, and also, are they applying them correctly? Are they utilizing a excessively conservative approach to various aspects of billing compliance? You know, there is some value in going through and appealing those and saying, hey, you folks are being a little bit too harsh on this. Again, my expertise. Adhere to all timelines. If they tell you you get an adverse letter in, it says you have 90 days to appeal, make sure that you get that in. I would suggest consulting with your attorney as soon as possible, particularly if there's a big dollar amount involved. Make sure that you state your case appropriately, not only just, you know, we're appealing these, but clearly state the rationale for appeal. If you choose not to appeal or it's denied, there's just sometimes, well, I'll look at an audit, but kind of rarely, but, you know, there's just, they've got them dead to right, and there's just no foundation for appeal whatsoever. Sometimes that can lead to a prepayment audit. It can lead to, which is basically before they pay you for certain codes, they need to look at the note, and that can include modifiers such as 25 and 59 as well. You can usually do a lump sum payment all at once. You can also request that they offset any damages up against future claims. You can pay them off in installments, and that usually is a good option if the down payment is significant enough. They'll work with you on the installments. Billing, as far as getting things under control internally, in the interest of making sure that you have, you know, a tight grip on what's going on, ensuring the integrity of all billing that goes out the door. You should have some process in place, or you can outsource it to companies such as Healthcare Compliance Network. We do a lot of that due diligence type work in addition to I like to say we have two types of audits, proactive and reactive. You know, the reactive one is the one that you never want. The proactive one, which is having someone look at your documentation periodically, educating the provider or any staff who needs to be in the know on any deficiencies. And again, we have the three buckets: agree, disagree, and let's talk. And most of the time, that let's talk bucket is the biggest one right there. It's like you're saying something, but there's a chance if I put that in front of an auditor, they may not give you credit. So let's talk about how you can strengthen that documentation to facilitate, to make it bulletproof, as I say. Charge capture processes, that should be periodically looked at. Establishing policies and procedures is definitely of value. We're going to audit X number of charts on all the providers, you know, twice, 3 times a year. Make sure that if we have new providers coming into the organization, we give them a billing and coding 101 and then do an audit, things along those lines. Policies and procedures also to as far as refunds and identification of any possible overage that's been paid, or, you know, self-disclosure, things along those lines. Stay current on the coding. I did an audit on site recently. A provider had a CPT 2011 book, which can give rise to those situations I mentioned at the onset, you know, billing for deleted codes and things like that. And make sure that, you know, all of this is concentric to your EMR. If you're still using EMR, make sure that it does an effective job at capturing all of those elements which are integral to billing. And every now and then have someone take a look. Make sure, look at that output. You know, what would an auditor be seeing in the event of a review if they're asking for the notes? Does it have all the elements to support the billing? And that, folks, leads us to the Q&A portion. If there are questions, I'm happy to address them.
Thank you, Jim. I'm now going to read the questions from the question box. If anyone has any additional questions they'd like to ask, please type them in the question box located on the right of your screen now. So I'll get started with the first question. It says, what do you consider a consultation? If the PCP sends the patient for a consultation for ear infections, the specialist recommends putting tubes in the ears and schedules the procedure. Sends back the report. Is this really a consultation since you treated the patient? According to the definition, when billing a consult, you are not providing treatment, you are advising on treatment and sending back for PCP to follow up the plan of care, correct?
So in that situation, it actually could be billed as a consult if there's some uncertainty as to one or more aspects. Number one, if there's uncertainty as to what the condition itself is. In this situation, doesn't sound like it. But number two, you could be asking for a provider could be asking for a consult because they're not sure how to treat it. The patient has chronic ear infections. They might be a candidate to have tubes placed, but there's some uncertainty there. I think the uncertainty is the key part of it, though. If something is a foregone conclusion, patient has a fracture and or something like that, and you're referring them for definitive care of the fracture, there's really no opinion per se that's being requested because the condition is known. The modality for treating that fracture is known. It's just the PCP doesn't do that type of service. In those situations, it's likely not a consult. If there's uncertainty as to the condition or how to treat that condition, now you're getting into a situation where, based on the guidelines, you could probably bill that as a consultation. Do you want to? Given the scrutiny that I'm seeing nowadays, I would think twice about that situation, even though I feel it technically might pass muster in the event of an audit. It may not. And that's an area I can tell you where I have seen 6-digit recoupments. So I would say tread carefully when it comes to consults. And I know a bunch of providers that won't bill them at all for exactly those reasons. And you just have to make sure you document that in the manner suggested. And I would be, let's say, careful at the very least in that situation, even though I feel it could be, quote, argued to a consult. It's not a path that's comfortable to be on, to need to have to argue anything. So.
Okay, the next question is, earlier this year, Horizon began to deny billing PAD 9392326 when done in the office. Appeals not successful. Any words of wisdom?
Could you read that again to me? The actual, was that a code number? Or is that a denial code? Can you just read that again, please?
Sure. It says Horizon began to deny billing PAD 93923-26 when done in the office. Appeals not successful. 939-26.
So as far as -26, I'm assuming we're talking about a diagnostic service that has both a professional and a technical component. Sometimes that's a payer-specific thing where they want you to bill for both the TC and the 26 modifier inclusive in one code that does not have any modifier whatsoever. And by doing so, you're attesting to the payer that you perform not only the technical component, but also the professional interpretation as well. If the requester wants to email me or give me a call with more specifics on that situation, I'm happy to address that outside of this meeting today.
Sure. The next question is, Mr. Tudor has referenced an MD being required to see the patient along with associate professional staff for incident to billing. This also applies to DO physicians, correct?
It does. MD and DO are subject to the same rules, yes.
You mentioned modifier 59 but did not expand on it. Please explain excessive use of modifier 59.
So modifier 59, as I mentioned, that all is tied into those Medicare edits that we discussed, the CCI edits, in which case sometimes the in modifier use, more specifically 59, would be appropriate to bill a constellation of CPT codes to report a particular service and other times it may not. And the problem is sometimes, for example, the documentation doesn't support it. Sometimes a modifier 59 is used when it's not even required to begin with. So the payer looks at your billing distribution and says, wow, according, what I'm seeing here, they're billing twice as many modifier 59s as similar practices in the area. And it may be appropriate, everything that's being done may be appropriate, but just by the sheer volume of it. And to be clear, this is predominantly situations that involve multiple procedure codes, which could, again, there's that whole conundrum of, is everything bundled into a comprehensive code, or you can, under some circumstances, can you bill separately? That's the type of situation it's referring to. And, again, it's the utilization statistics, which are the driving factor. Again, probably 20-25% variance, similar to the E&M codes. So if you're putting 59s on, and this one situation in particular with Horizon, I can tell you one practice was gotten in hot water for high volume of modifier 59. They were putting it on almost all secondary codes. Like there could be 3 or 4 codes. It was primary care situation, like patients seen for a well visit, and there was maybe 3 or 4 different billable services, and they were putting the 59 modifier on all of the subsequent, the non-E&M codes, and it wasn't necessary on any of them. The only way to know for sure if it's necessary is to look up the CCI edits. So by overutilization, it's typically a scenario like that that's the underlying problem.
When you reference modifier 59, are you including the X modifiers?
Yes, so the X modifiers are what I call the spawn of 59, and they make separate distinct, they're used in a similar fashion, which is, you're billing for multiple codes over the course of the day. You're using, instead of modifier 59, you're using a more specific subset of modifiers, such as that delineate a separate practitioner, a separate anatomic location, an unusual service. It's basically modifier 59 drilled down with more specificity, because if you look up just the CPT definition of modifier 59, it's not really all that helpful. It just says distinct procedural service billed on the same day as another procedure or service. The X modifiers, which are pretty much, it was started as a Medicare thing about 5 years ago, but for the most part, all payers are accepting them now. And you should strive to use those X modifiers in lieu of 59 when the rules apply. Separate practitioners, sometimes you'll see over the course of a day, a group practice will see, for instance, the MD in the morning and then another provider in the afternoon. Depends on the circumstances, but there's an X modifier for separate practitioner or separate encounter, which lend a lot more clarity to the situation than 59 itself does. So my recommendation would be to absolutely use the X modifiers when the rule applies.
I have patients that see one of our doctors as a consult and then is transferred to another doctor in the same practice. Are they both able to be billed as consults?
So if provider B in that situation is a subspecialists typically can bill for consultation. So it's, even if they're members of the same group practice, it's entirely possible that that may be the case, such as cardiology does a consult and then they refer to an EP specialist within the group. Situations like that, absolutely. You'd have to check the CMS specialty designations, which are found, you could easily find as online. Anything that has a separate specialty code can usually bill for a consult, general rule.
Okay, the next question is, I don't understand the part of using modifier 25. We use it a lot when a patient has a breathing test and sees a doctor on the same day. We are a pulmonary practice and most of our patients need a breathing test when they come in. This is pre-scheduled. Are you saying that we cannot use the modifier if the visit and procedure are planned ahead of time?
So if really what's happening in that situation was, yes, it was pre-planned, the breathing test, but it was also a full evaluation of that particular underlying condition. And I actually see a ton of that, providers who are audited, and ultimately that's an area where they're fairly lenient with you there, as long as that full medical evaluation for that problem. So it's good. It's a lot more than just the breathing test itself. That would be absolutely a situation where the modifier 25 would be supported. If they came in and just did the breathing test without the full evaluation, that would be another matter. But usually, in my experience, that's not the case. There's usually just a patient was also due for a follow-up for the COPD or whatever the condition was. And so that sounds like a valid modifier 25 situation on the surface.
Okay, the next question is, if the clinical report of a radiology study does not have a clinical finding, can we use the DX on the referring doctor's order?
Yeah, if there's no definitive diagnosis, you would code that in accordance with whatever the symptom was, which assumedly is tied to the order. So yes, absolutely.
For primary care, can a new patient be seen by a mid-level practitioner?
I'm sorry, could you read that again?
Oh, patient. I'm sorry. For primary care, can a new patient be seen by a mid-level practitioner?
They could. In primary care, the thing about that you'd want to watch out for is if you're billing incident to for follow-ups of those conditions were addressed by the NP, let's say, in the initial visit, they couldn't be billed incident to. They would have to be billed under the NP, unless the doctor also came in the room and says, okay, for your hypertension, we're going to do this, your diabetes, we're going to do that, and Nancy, your NP, is going to follow you for those conditions. If the MD doesn't do that, then under the Medicare rules, all of the subsequent visits for those conditions that were initially addressed would have to be billed out under the NP as independent services, thus reimbursed at 85% instead of 100%. But yes, they could see patients, yes.
Okay, the next question is, United Healthcare has started denying level 4 and level 5 claims for emergency providers. Appeals not successful, and our documentation is on the spot. Any feedback?
Yeah, I would like to see those, quite frankly, because in the emergency department, it's a level 4 friendly type of situation, to be sure. I would find it kind of strange that the appeal rate there is not being successful. Even a pretty fair number of level 5s, if I'm recalling the billing distribution correctly there. My suggestion would be to either engage outside consultant or someone who's seasoned in that situation, and or confer with someone directly at the insurance company, probably someone higher up, to say, hey, look, we've got what we feel are a lot of level 4 visits that you folks are denying. And we require a valid explanation as to what's going on here. Is it because we're not is our documentation insufficient? Think earlier, my whole discussion on meeting the exam and the review systems and all of that. Is there something missing there? Or are you folks truly downgrading us based on the decision-making and or medical necessity aspect? It sounds like you need answers, and I would press to get them.
Can mid-levels do an initial assessment of an ADHD patient?
Yeah, again, kind of like along the same lines that we just discussed, they could do the initial visit, but if the MD doesn't come in there as well, the follow-up visits for ADHD would have to be billed under the NP and not, an incident 2 type of scenario.
Okay, the next question is a little bit of an example. Example 99213, 99401, and flu vaccine. When we billed 90471, they seem to deny the 99401 as an inclusive to 90471. How do we separate those, 59 or XE?
So if the counseling in that situation is related to the flu shot, you wouldn't bill the 99401 to begin with. If there's another aspect of preventative counseling, because that's what the 99401 code represents, if there's something else associated with that picture, you could appeal it. It's the 99401 is a time-based code, by the way, and you'd have to, I believe the code description says approximately 15 minutes. But if it's all that counseling, if the reason you're billing that code to begin with is related to the flu shot, then I wouldn't bill it at all, because the counseling that's inherent to providing the flu shot is included in the 90471 code.
And the last question we have here is, why is an annual physical denied as inclusive to CPT 94010?
I'm assuming that's 99401, the same code that we were just referring to. And the reason for that is preventative counseling well, it should be, if they're going to bundle in that situation, they should bundle the 99401 into the physical, not the other way around. Because inherent to the well visit codes is preventative counseling. So it stands to reason. That's a fairly straightforward situation there. If you look in the CPT section notes, it specifically tells you not to do that. But if they're bundling the greater value code in this situation into the lesser value code, that's something that should be appealed. But it would be technically incorrect to build those codes together. It's not eligible for a modifier. But make sure that they're doing that right, and please don't bill the 401 code together with a well visit, because that's actually had somebody got dinged on that recently.
Sure. She did clarify that 94010 is the correct code, not the 401 that you mentioned.
Oh, 940. Okay, so that's like a pulmonary test. So that in that situation, my advice would be, if you're not doing it already, would be to put the modifier 25 on the well visit. Now, usually the modifier 25 goes on a problem-oriented E&M code, i.e. 99213, 214, and so on. But technically speaking, the well visit codes are E&M codes. So you could certainly try to do that. If you're already doing that and they're still denying, similar to the example that I'd mentioned, and that I would assume too is similar, because they're trying to deny pay you for a lesser value code and bundle the greater value code into it, which is not appropriate. That's just incorrect. And if the appeals are not successful, then you need to continue to press that until you speak with someone who can explain it to you. I can tell you, if you're doing, my opinion, you're doing a full physical and you're doing, if that's a spirometry or some kind of pulmonary test, it's usually quite separate and distinct. There's no overlapping elements whatsoever between those two codes. It's just the denial itself is absolutely incorrect. And I would keep pressing until you get an answer on it.
And she wrote in one more time, it usually happens when we bill the physical and an EM code as well.
Okay, so if you're billing, the three codes together, physical, E&M 99213 or whatever, and the 94010, still, I'm thinking, that might be a more difficult situation to challenge because of the presence of the additional code in there. But if you're addressing a problem, and by addressing that problem, it goes beyond all the work associated with the pulmonary testing, there shouldn't be any issue in getting that paid, both the office visit and the 94010. Same answer, really. You need to keep pressing on that appeal, and if that's not working, you need to speak with someone who can explain it to you. And then, by all means, feel free to reach out to me personally with more details regarding that. Maybe I can help.
Okay, the next question is, can nurse practitioners bill Incident 2 and as a regular provider in the same office?
So can nurse practitioners bill Incident 2? Can you read that again? I'm sorry, that one.
Sure. It says, can nurse practitioners bill, in quotations, Incident-2 and as a regular provider in the same office? So
when we're talking about Incident 2, we're talking about billing under the doctor. They don't have to do, I'm not sure that maybe this is another one where we need clarification, but it's possible to bill in any given encounter as an Incident 2 encounter and to bill, next week, if they come in with a URI, for example, it's not related to any chronic conditions or anything like that. There's no need to engage the physician whatsoever. It's entirely handled by the NPP. That visit probably should be billed as an independent service under the NPP's billing numbers. It's usually the chronic conditions that are billed out as incident too. So I'm not sure if that's what that question is directed at, but feel free to clarify or reach out to me directly.
Okay, the next question is, if we provided additional information for a BCBS audit, how long do they have to respond back?
Yeah, and that's very common, by the way. And in fact, out of those 10 average cases I'd mentioned, probably 3 or 4 of them, they just didn't get all of the information the first pass. And they're surprisingly good about accepting that. We did get, I'll tell you, one of the hot spots lately is signatures, especially for those folks who are still using a paper chart. They need to be able to identify the practitioner. There needs to be a date, a discernible date when that was signed. You could fill out a signature log and send it in after the fact. They prefer that you do that up front, but if they end up denying a bunch of those because they couldn't identify the provider, that would be an example of something you could submit. And it typically takes them about 30 days to rewire the results there. They'll give you credit for it. If they can prove, what they're looking to prove, they'll accept it and they'll give credit where due. But on the average, if the question is how long does it take, it's usually about 30 days.
Okay, we have an orthopedic question. She said she's having an issue with EM codes getting paid with 24 modifier for a left knee service when the PT is in the post-op period for the right knee. BCBS is denying even the appeals.
So in that situation, you have to make sure that your diagnosis code is accurate, number one. So if patient is seen, they've had, let's say, a left knee replacement, they're seen in the post-op period for a right knee, you want to make sure you use your diagnosis for the right knee on the claim. Modifier 25 would be appropriate in that situation. It should absolutely, positively, if you're doing all of that right, there's absolutely no reason why that shouldn't be paid. And again, it's like sometimes you need to push a little harder on situations like that in order for them to acquiesce. But I think that's, and again, that's a situation I'd be happy to take a deeper look at if you wish, but that one should be paid. Absolutely should be paid.
Okay, so we have no further questions for today, so we can wrap this up. The presentation slides will be emailed to all participants and will be available on our website for members only, as well as a quick survey will be sent out because your feedback is extremely important to us. If you have any additional questions, please reach out to the presenter directly. Thank you everyone for attending, and thank you, Jim, for a great presentation. I hope you all have a great rest of your day.
Bye, folks.